Good afternoon, everybody. Welcome to another edition of the AFR EMS podcast for case study review. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue, and today I am welcoming Captain Noah McGilvery from Station 20. Welcome, Noah.
Thanks, Chief.
So thanks for meeting with us today to talk about this important case, and today we're going to discuss sepsis. Engine 20 was dispatched recently to a 26 Charlie for a 47-year-old male not feeling well. Can you describe to us what you saw on this call and what you were doing en route?
Sure. We went en route on this call, code 3 for the 70-year-old male, or 47-year-old male. He wasn't feeling well. It really was just kind of a typical call. 26 Charlies can often be nothing, or they can be really sick. So it was kind of just a general code 3 response to this call, nothing special popping out.
Okay, great. And when you got there, what did you see?
So this part was pretty interesting. We arrived on scene. The father was actually the one who called 911 for the 47-year-old patient. We were greeted at the door by the father. He was, concerned that his son was not feeling well, had been weak, not getting out of bed. He said he'd been partying out late a lot, coming home, was concerned. The patient actually came down the hallway and was surprised that we were there, frustrated, started telling us, get out of my house. I don't want to be assessed. We started to go down the non-patient route, asking him, trying to figure out if he's decisional or not. He was confused, had some slurred speech, a little ataxic. From that, we decided he probably wasn't decisional to refuse. So we tried to verbally, de-escalate the situation, tell him, we're concerned about you. Can we get you to sit on the couch and check your vital signs? So he cooperated, and my driver went over, spoke with him, started to get history from the patient, and then I spoke with the father a little bit more.
That's key. So when you originally encountered him, he didn't want any of our help and just said, get out of my house. So initially you're thinking along the lines of taking that refusal, but just based on your intuition, what you saw, his presentation, you felt like he may need it. So you were able to discuss with him a little bit further and get him to agree to an assessment?
Yeah, definitely. You just, you get the gut feeling of, this patient doesn't look well. And then you also go down your algorithm there, and you figure out, is this person decisional to refuse? Doesn't seem like it. He's confused, slurred. So we should probably try to figure out at least if, he's sick or not, or intoxicated.
That's great.
Go from there.
Great. Good job catching that.
Thanks.
All right. So talk us through your initial assessment, your discussions with him, any basic vitals. How did that assessment go?
My driver kind of started the assessment with the patient while I was talking to the father. Like I said, the father said that he had been out, partying, coming home. He hadn't gotten out of bed pretty much all that day, had been vomiting. He was really concerned about it. The patient looked sick. He was, like I said, he had some slurred speech. He looked pale. Just didn't look well overall. In the hallway, it was pretty dark, so we didn't see him very well at first. But once we got him to the light, he didn't look. He looked like a sick patient. His blood pressure was initially 66/40. We didn't pick up an OT saturations because his perfusion was so low. Respirations initially were 16 to 20, a little bit elevated. His capnography was low at 24. His temperature also read low, and we were unable to get a blood sugar because he wasn't perfusing his extremities. So right off the bat, after we were able to get that primary assessment, he was sick. His ABCs were intact, but he definitely met all 4 criteria for the modified Sears sepsis criteria. So,
and did he have any history that led you down that path?
Not really. So initially he just said, I don't feel well. I've been vomiting and I haven't felt sick. It hadn't been until, the ambulance arrived on scene, got him into the back of the truck, that he had discussed that he had been using IV meth. And that we also, it's, looked like he had an abscess on his AC area.
Okay. Talk about some of the interventions that you guys did once you recognized how sick he was and what your thought process was down the sepsis route.
So like I said, he met essentially all 4 of the criteria for the sepsis protocol. We tried to get an IV initially, which was unsuccessful. His vasculature was, was a very hard IV stick. We did a 12 lead, which was sinus tachycardia. There wasn't anything abnormal about that. 5-5 arrived. The ambulance arrived on scene. We got him loaded up. we just recognize this, this patient is really sick. He's probably most likely septic. He's not perfusing well. He's not mentating well. So we need to get a line going and go down the sepsis route and, get fluids on board as well as start the norepi drip. So, my crew was awesome. They didn't have, pretty much any prompting. They got him on end-tidal, did the 12 lead, try to get a line going, got him prepped to go. The 5-5 medic was, one step ahead of me getting the IO prepped as well as levo-fed. So everything flowed from there, and we got the IO established and then started the norepi drip on the way in.
All right, so you hit all the markers. You said he was tachypnic, he was tachycardic, he had low CO2, hypotension. You knew that the pressors and the fluid resuscitation were going to be key. IV access was difficult to non-existent. Mm-hmm. And you guys then decided to start the IO, which isn't always an easy decision on a conscious patient. How did that go? And talk us through quickly on what you did to talk him through that procedure.
We pretty much explained to him, your vital signs are very abnormal. You seem sick. We need to get access to give you some medications and some IV fluids. And so we're going to have to do a procedure on you that, is going to hurt, but we'll give you medication right afterwards that will keep you comfortable, or do our best. The AS Meta walked him through it, did a humoral head IO, pushed it, we gave him lidocaine, and, he seemed to, after a few minutes become comfortable with the procedure there.
Excellent. Talk me through your titration of fluids and the pressors that you chose.
So we kind of talked about this a little bit. Our protocol states if you can, you want to try to get a liter of fluids on board before you start the pressor. We had this conversation in the back of the truck, do we want to get the pressor started right away, or do we want to get the fluids on board? We had this conversation, we went back and forth, and we decided, this patient's really sick for all the reasons that we already discussed. We'll continue to give him fluids. I think we've got about 250 on board, but he really needs his pressor right now. He's not perfusing well. His skin doesn't look well. He's not mentating, and he needs a better blood pressure. So we decided to just go ahead. We started at 4 micrograms per minute and then started to titrate it up. Eventually, we started at 4 micrograms. We continued. We couldn't get a blood pressure manually en route. It was too hard to hear. We didn't have radial pulses, so we continued to titrate that up. We got to the ED, and I believe we, finished out at 12 micrograms per minute, and he still at that point did not have radial pulses.
Gotcha. So it's a relatively newer med to our agency, not so much in the system, but norepi is new to us, levo-fed. Just talk us through quickly on how you mix that, just so everyone's comfortable with it.
Okay. And then one thing I did want to add on top of that we also discussed is, we have norepi as well as epinephrine to use, in this situation. But we talked through this as well. The norepinephrine has less effects on the heart. We were thinking this is more of a, a volume and a vasculature problem, which norepi affects, has a better, does a better job of treating. So essentially to do that drip, it's fairly easy here. We have 4 milligrams in 4 mLs, so we want to drop 1 milligram and put it into 250 cc's here. So that would be 1 ml in how it's packaged here for us. You go ahead and spike it with a 60 drop set, put that milligram into the 250 underfill, and then that'll give you a concentration of 4 micrograms per milliliter, and then you're going to go ahead and start that running. If you do about 60, you started at about 60 drops a minute, 1 drop a minute, and then you titrate that essentially up to where your vital signs, if you are, titrated up to a good blood pressure or an improvement in mentation. And obviously, if you have a pump, you want to run it on that. That's going to deliver the most appropriate amount of the medication.
Awesome. Great job on that. You and the Station 20 crew did a fantastic job of helping that patient. Now we know that early notification is key. So you made that early notification to the hospital to let them know you had a potential sepsis alert.
We did,
You tried to get that medical contact and transport done within that first 10 minutes once you recognized how sick he was. Just describe to us quickly when your turnover at the hospital, what the patient's condition was and how he improved.
To tell you the truth, his mentation didn't change that much. We started the IO and we started to give the norepi, but the 10 or 12 minutes that he was in our care, he didn't really improve that much. He didn't decline. We might have had a little bit of an improvement in his mentation. His vital signs, were still unstable. We still didn't have radial pulses. So he was hypotensive, but he had a little bit of, a slight improvement in his mentation, but other than that, didn't have enough time for the treatment and the fluids to probably kick in.
And that's what's key. We talk about this is not going to be a definitive treatment that we're doing right now in the field that we're going to see the repercussions from, right? But it's going to start a process. It's going to get the receiving hospital thinking about what they're going to receive, and just creates that continuation of care for them as they move along, because it's going to be a long-term recovery for that individual. But you definitely set them up for success, and it sounds like you guys did a fantastic job. So I appreciate you for the care that you and your team provided, but for two, coming out and talking with us today about a medication and a procedure that we see it probably more than we even recognize. So for the ability for you to catch it early, treat it quickly, transport and notify was an outstanding job. So thank you once again.
I appreciate that. Thanks for having me. Give a shout out to my crew and that Albuquerque ambulance crew as well. They did a really good job.
Awesome. Thanks, Cap.
Thanks, Chief.
Thank you for joining today's podcast to talk about sepsis. We'll be back next session. And if you have any ideas or thoughts or recommendations to send for case review, please input those through SharePoint. Until then, we'll see you next time.